Hello, everyone, and welcome to the Maternal Child Nurses Interest Group webinar today. As part of our ongoing MCNIG career series, this month we are introducing nursing careers in community birthing hospitals. And this may include level 1 or level 2 hospitals in the GTA or across Ontario. Today we'll have 4 guest panelists speaking for today on behalf of Ms. MCNIG. Our first presenter is Haley Dallas, who is an RN in the labor and delivery unit, primarily at Lakeridge Health. Our second guest speaker is Pamela Garncarrick, who is a L&D nurse at Georgetown Hospital, as well as Mount Sinai. We have Coral Dalzell, who is a labor and delivery nurse at the Sioux Lookout Menayawin Health Center. And lastly, we have Orly Benson, who is also an L&D nurse at Michael Garron Hospital in Toronto. Just a heads up that we will be recording today's session, so if you need to leave early or would like to share the webinar with any colleagues or friends, feel free to do so. It will be posted on our website, www.mcnig.ca. Once every presenter introduces themselves, we'll open up the floor to a Q&A session with all the guests. So feel free to type in the chat, or you can unmic yourself and ask directly. So to start, we will have Haley introduce herself.
Hi, everyone. I'm Haley. I'm an RN at Lakeridge Health, Port Perry, and Oshawa sometimes in labor and delivery. I went to school in Nipissing University in North Bay, so about 3.5 hours north of Toronto. I started working L&D right away. I actually consolidated where I work now. So we do L&D postpartum follow-up assessment clinics. We do lactation help as well. So it's really holistic in terms of we see our patients from start to finish, which is great. I have obtained my Prenatal Certificate. I'm enrolled in a NICU certification course right now, and I'm actually writing my Lamaze birth educator exam in November. So I've been shadowing a nurse who's a Lamaze educator, and I'll be kind of taking over. So I write my exam in November for that. So that'll be nice to follow our patients through every stage. So that's more the antepartum and birth education. I chose L&D. I didn't know I wanted to do it, and then I consolidated and I really fell in love with it. And I just really love seeing the strength of women and pregnant people every day. And I really love supporting them during their strongest but most vulnerable moments too, right? It is such a changing time in someone's life, whether it's their first baby or their 6th baby. It's amazing. So it's nice in a smaller community setting that you do follow them through all different steps, labor, postpartum, after, like I was kind of saying before. Because I don't have to really compare what it's done for the last 4 years, but I've become assertive in cold one setting. Our doctors don't stay in house, so we're making decisions sometimes. We're calling the doctor, we're calling a team all at the same time. And that comes with knowledge, skill, and time. We're never paired with someone. You start with someone who's senior, and then you're paired, and then you learn, and you do learn that knowledge, skill. And then you can make those decisions, which now I have people who have less seniority than me, and I'm teaching them, which is really special too. I plan to stay in L&D forever. I hope so. And anyone that is looking to go to L&D, it's really just brings it all back to the basics, your basic nursing assessment skills, your intuition, like always go with your gut. I find a really big one is advocacy and consent for your patient, because sometimes when they're in the heat of the moment in labor or transitioning, and you've talked to them before, you've got to know them before they've heavily started laboring, maybe you can really advocate for them, which is really special. it's really amazing to see what the pregnant and labor and delivering person, their body is capable of. I love that. And it's such a special time. It's such a sacred time, and it never gets old. I know that sounds cliche, but it's really special. And just don't forget that the basic human needs, touch, encouragement, love, that's such a huge thing and such a special but private time in someone's life. But yeah, that's what I have to say.
Awesome. Thank you so much, Haley. I think everyone can resonate with some of those sentiments with you. Next up, we have Pamela.
Hi, can you guys hear me?
Yep.
Okay, perfect. I'm Pamela. I went to Ryerson University. I did the George Brown Collaborative Program. I'm currently working at Georgetown Hospital, which is a small level 1 community hospital, which is similar in the fact that doctors don't stay in-house. And then I'm at Mount Sinai, which is a high-risk level 3 hospital, so I kind of get the best of both worlds. I consolidated as well in my 4th year in obstetrics, and that's kind of when I fell in love and knew that that's what I wanted to do. I didn't initially start off. I actually started off in working in long-term care, which is a completely different spectrum. Did that for about 8 months, but in the meantime, because I knew I wanted to do OB, I was doing the Humber post-grad obstetric courses. And then that's when I got hired at Mount Sinai. That would have been about 3 years ago now. And some of the other certifications that I did to work in the area would be like the NRP, BLS. I did do the stable course, which is more related to NICU and resuscitation and management of a sick newborn. Also more OB and just certain courses that Sinai offered for management of obstetrical emergencies that were really good, and bereavement courses just to help with management and helping families cope with stillbirth. I chose L&D because I've always been beyond passionate about obstetrics. I always like the that it's a multifaceted and highly variable area of practice. Every labor is different, whether it's someone having their first baby or their 6th, like we said. It's very different and it's always challenging. And there's a little bit of that rush of adrenaline that I love when there's responding to emergencies. And I just always loved how it incorporates so many different skills in your practice. So like, for instance, I get to do postpartum nursing, triage, PACU, operating room scrubbing and circulating, newborn management. So there's just so many things incorporated into one area of practice, which I've always really loved. And just the whole assisting a family into bringing new life into the world is so beautiful, and it makes you so knowledgeable, resilient, and just empathetic, which I've always loved. I think L&D is where I always wanted to work. That's like what I'm most passionate about. The only other area of nursing I would potentially consider pursuing is NICU, but more so or pediatrics, but more so I say that only because of working in a small level 1 facility. You don't always, like in L&D, I'm kind of always confident in my critical thinking, my skills and my decisions, whereas managing a sick newborn post code pink resuscitation, there's always that bit of, because I'm not an NICU nurse, but we don't have an NICU, so we stabilize these newborns. I would like to have the NICU skill set just so that level of feeling overwhelmed and stressed isn't as bad. So I think that's the only other area of practice that I'd want to work in, not to leave labor and delivery, but just to acquire additional skill set, just so that I could have more confidence. And like a sentiment of advice that I would offer is to always run towards opportunities and challenges and not be afraid, because really that's when you learn best, is when you're put into that situation, whether it's not your patient, whether it's a colleague having a bratty and you run in to help. Those are the situations where you're really going to learn what to do and how to respond. And network, always create the relationships with professional relationships, whether it's with other obstetricians or people that are involved, so that you can attend, meetings and conferences and things that will help you learn and improve in your career and wake up to the job that you always wanted to have.
Amazing. Thank you so much, Pamela. Next, we'll have Coral.
All Right, hi, my name's Coral. I have been working as an RN at the Sullicut Minnehaha Health Center for the last 4 years and in maternity for the last 3. So for those of you who don't know where Sullicut is, it's about 24 hours north of Toronto, and more specific, like 6 hours north of Thunder Bay. So we're a very rural, very rural community, and like the rest of these girls too, we incorporate a little bit of everything into our practice. So we do prenatal care, labor and delivery, postpartum care, and then outpatient care after babies are born as well, and they've been discharged from the hospital. We also obviously don't have a NICU, and we are responsible for stabilizing babies until a NICU team from Winnipeg or London can come pick up our babies and transport them to another center. And also the same thing, like doctors don't stay in house. All of our doctors are family physicians that just have like an extension to do OB practice. We do have like one actual OB that comes up from Thunder Bay every once in a while to have coverage and see patients and stuff. But so I went to school at Nipissing University, graduated in 2017. I did my consolidation in Sullicut in Emerge, and I really enjoyed it. Originally thought I wanted to work in Emerge, but after I got hired at the hospital casual and worked on the nursing floor for about 6 months. I really didn't like it. Really wasn't sure that I even wanted to continue doing nursing. And then 3 jobs came up in labor and delivery had always been something that I was interested in school, and didn't get much of an opportunity to in school. So as much as it wasn't really my plan to go into labor and delivery right away, I thought I maybe wanted more experience first before I went in. I kind of just took the leap and went in and got a full-time position. And that's where I've been ever since. I've had to do some education related things for my job. So I do have NRP, doing the fetal monitoring course. We have an upcoming class about perinatal like bereavement and everything to help with women who have miscarriages and stillbirths. And beyond that, like basic like BLS certification, and I've done like some reading like on my own. I haven't been able or had the opportunity to really take any additional courses, but that'd be something I would be interested in doing in the future. I chose L&D partly because I just wanted to have a change and like see if there's another part of nursing that I really would enjoy a little bit more. And I do. I really love my job. It's really helped me come kind of more into who I am as a nurse, and I feel a lot more sure of the career path that I've chosen. And sometimes I think that's just what you need to do. You need to kind of explore a little bit and figure out what really fits you and what you're more suited to. I also I love the idea of being able to be in such an important moment in these women's lives and in these families' lives. And it's something that the average person is never going to see like more than maybe once in their life. And I've seen it like hundreds of times. And I am still just in awe every time I see that just like a new life coming into the world and being able to support a family, support the mom, and into the transitioning into a new role that she has now. And since I've started this practice, I feel the biggest thing that probably I've been able to come out of it is definitely being able to be more confident in my decision making, and like Haley said, like trusting your gut. Like my doctors don't stay in house. Sometimes like you have to make quick decisions about things wherever you think something needs to be looked at right away, or we serve a population that has higher gravitas statuses. So we see a lot of moms who are like G7, G8, G9, and a lot of these deliveries happen really fast. So I've definitely done my own deliveries because the doctors don't make it in time. And just kind of like knowing like even a little bit beyond your scope of things to be able to do and kind of immediate situation. Because we're so far away from a NICU, and sometimes we don't have the NICU team available to come pick up newborns right away, you have to manage these yourselves while also still managing a whole labor and delivery ward and laboring other moms and dealing with postpartum care. So get really good at prioritization and time management and everything like that. We also work primarily with First Nations population here, and I've just have so much more empathy than I think I used to Indigenous issues, and just the strength of this community, and being able to see how they have like so much working against them, but when you're in them with that moment, like when their baby is being born, and just you see like the strength that they have, and like and you know the things that they've endured, and you know some of like their medical history, their social history, and you just are able to, I don't even understand how to explain it. It's an amazing field to work in, and being able to work with this population. And I just really love that. And I don't think I really want to do labor and delivery anywhere else. I really love doing it here. And I love the population I work with. I love my coworkers and the team dynamic that we have. I don't think there's really any other things I'd really want to pursue, unless it was more like healthy babies, healthy children, more community-based, prenatal and postpartum care. I think I would really enjoy doing that at some point once I've gained a little bit more knowledge, and am a little bit more confident in some of my skills, especially my like breastfeeding assistant skills. But I would say if anyone wants to go into L&D, if that's something that you really feel like you might want to try, like give it a try. Like don't be afraid to try new things, and don't let the thought of I don't have like enough skill set, or I might not have this isn't like in my timeline or anything like that. Like just go for it. I went into it after 6 months, and I've been here for 3 years, and it's been fantastic. And it is a learning curve, but it's amazing, and I really enjoy it.
Amazing. Thank you, Coral, for sharing all your experiences. Lastly, we have Orly.
Hi, so my name's Orly. I'm an RN at Michael Garron Hospital, where I've been for just over 3 years now in labor and delivery. We are a shared unit at Michael Garron, so labor and delivery and postpartum on the same floor. So I mainly work in labor and delivery, but also work with postpartum and antepartum patients. For schooling, I went to Humber College. So I did my RPN first at Humber. And then after I graduated my RPN, I was kind of leaning towards working in labor and delivery or peds. So no, I needed my RN for that. So I bridged through Humber. So I have a joint degree through Humber and University of New Brunswick for my RN. Like many people, it kind of seems I did my consolidation in labor and delivery, and then I've been there since, which I'm very happy about, and I love working there. In terms of patient population, I think I've learned that kind of the healthy adult population is something that really interests me, and I give kudos especially to Pamela, who said she started off kind of working with the geriatric population, but not for me. I really enjoy our patient population. And I think I just love being able to make connections with people. So labor and delivery is very acute in the sense that your turnover is very fast, but we work primarily one-on-one with patients. So I think it's so nice to kind of be one-on-one with that patient and their family during this vulnerable time for them, and be able to make those really important connections with your patients, which I love about it. And I just love being able to be that support for women during this vulnerable time, and being kind of in that special moment in their lives. And especially where I work, so it seems a little different than Coral and Hallie for sure. We have OBs in house all the time, anesthesia in house, we have a NICU, we have peds in house, but we are very autonomous, but also work very well as a team. So I kind of like the balance that we're trusted to kind of manage our patients and deal with our patients, but the second you need teamwork, the team is there for you, which I really love and I think is great about our unit. In terms of other fields of nursing, I can't see myself really leaving labor and delivery, but I am interested in kind of stuff that builds on it. So I've taken some courses in bereavement, which really interests me, just learning kind of how to better support our patients in our population of stuff that's not your everyday. And I think eventually something more high risk would interest me, just kind of building on the knowledge that I already have. And for people looking to get into labor and delivery, I know specialties can be intimidating to try to get into, especially if you haven't done a consolidation there, because that's kind of a foot in the door for you. But I think it's just the willingness to kind of educate yourself. A few of the girls already have mentioned courses that you can take. So your NRP, fetal monitoring, stuff like that. So just take them and educate yourself ahead of time. And be upfront and be eager, right? So if your willingness to learn and willingness to show that you're willing to get these courses and learn, then that's going to help build your experience before you can get onto the unit and get the job on the floor. So just be willing to challenge yourself and put in the effort to work in those specialties.
Awesome. Thank you, Orly, so much. Now we can open up the discussion to the guests and participants. Please put your questions in the chat box, or you can feel free to raise your hand and unmute your mic if you would like to ask a question. The first question is from Eason. I think I'm saying it correctly. For those who did consolidations in L&D, how did you get those placements? And did you apply, or was it a lucky random assignment?
I can answer that one if you want. So when I went to school, you had to apply if you wanted to work in specialty areas. So you needed a certain GPA in order to apply, and then you could apply and rank your specialty areas. And you had to do resumes, like clinical resumes and cover letters. And I was pretty persistent with mine, and I don't know how different schools work, but I was pretty persistent that I wanted to work in L&D. So it wasn't a lucky random assignment, like you were applying specifically for where you wanted to work. What was random was where you got placed. So you could kind of set your boundaries for locations of where you wanted to get placed, and mine was anywhere in the GTA. So it was random that I got assigned to Michael Guerin, which I'm very happy about now 3 years later, but random in terms of location, but not random in terms of specialty.
Thank you, Orly. Did anyone else have a different opinion or perspective that they went through?
For us, actually at Ryerson, it was all random placement. We didn't really get to pick what area we wanted. And in my 4th year, Ryerson's placements actually weren't the best. It's basically all geriatric care, acute care of the elderly, or long-term care. There's very few specialty areas that they place students in. So for my final year, they placed me in palliative care, and I brought it up to the director and said, no, I don't want to do this, because my whole 4 years has all been around geriatrics. And then they actually said, how would you feel about obstetrics? And I said, I'd love that. So that's the only way that I got it, but it's all through random placement. And if I hadn't kind of fought for it, then I would have ended up in palliative.
For me, it was about connections I made beforehand. I actually came, Port Perry is my hometown, so I came back here. You can apply to do an out-of-town placement. So when people stayed back in North Bay, you had placements within North Bay. I applied to come back home. I almost didn't get the placement because the placements in my hometown were going to the more local university students, which is fair. I eventually got it, but I made some of the nurses advocated for me and were willing to take me on. And I had done a lot of volunteering within the hospital as well, so I was familiar. So sometimes if you want a specific hospital, sometimes get put in the door that way because you can't be employee yet necessarily. If you volunteer, then your name is familiar within the organization. So that, I think, helped me a little bit too.
I didn't do mine in obstetrics because I didn't want to do that originally, but I went to the same school as Haley, and so our school gave you, if you wanted to do an out-of-town placement, you had 3 options for, you could pick what hospital and what department you wanted to work in, and then give your three options, and then they would reach out to the hospitals and see who's willing to take you on. I'm one of the only people that kind of left Southern Ontario, because I'm from up here. So I was okay with kind of coming back up here. I was kind of trying to encourage other people to, if your school allows it, try to do placements in more rural, like northern places, because there isn't a lot of people that apply up here. So I was able to get my first choice in my first department that I wanted. So like, and our placements are 4 months long. So it was nice to be able to be in one place for 4 months. I know not every school is like that, but I would give that as an advice to nursing students too, is like, don't be afraid to like go out of your comfort zone in terms of geography if your school allows that, because you will be able to probably have more opportunities, and it's not as competitive as in like Southern Ontario. So.
Yeah, that's great advice. Thank you, everyone. I highly agree with what Haley was saying. You know, volunteering, especially now with COVID, there's lots of opportunities for students and nursing students, especially. They like hiring nursing students as clinical externs or even COVID screeners, you know, those little things just to get yourself into an organization, understand the organization, try to find units that you might be interested in working in or having a placement in, and connecting with nurses and managers directly. Because yeah, just getting your foot in the door any way possible and not kind of relying on your school to, you know, advocate for you or try to find the best placement fit for you. Trying to reach out yourself is definitely something I would also recommend. I also went to Ryerson, and my 4th year placement was in long-term care, unfortunately, but my pre-consolidation, so the September or the fall placement semester, I was lucky to get an obstetric placement at Mount Sinai, which is kind of how I continued to build my relationship with my preceptor. And then by the time I graduated, I just connected with the manager through my preceptor and was able to get hired right after my NCLEX exam. So it's all about connections, who you know, and really putting that effort in yourself to reach out. Our next question is from Karen. She asked what a typical patient ratio in L&D is.
When someone's in labor, it's always 1-to-1. If you work at a place that you do postpartum as well, at our hospital, you can have up to 4 dyads. So a dyad would be a mom and baby. Sometimes it could be mom and babies if she's twins. So then you'd have 8 people in your patient load if you had up to the 4 dyads. In terms of someone antepartum, you could have like 2 dyads and 2 APs, we call them. So those are people who are in the hospital. They need to be watched essentially. So say you had someone with a full previa and they need to be watched in hospital because they've had some bleeding. So they're usually a little bit of a lighter load because nothing's actively happening, but they need to be in hospital close to an OB, an OR, etc. So it really just depends what your patient load is that day, but always when someone's in labor, 1-to-1.
I agree. Same at our hospital. Early labor, sometimes we have 1-to-2 if they're not really doing much, like if they're inductions who came in just to be watched, but active labor, 1-to-1.
In an ideal world, in labor and delivery, you can 1-to-1 your actively laboring patients. That does not always work out. We have 2 nurses that work, 2 RNs that work on our floor at the same time, and sometimes you're laboring more than one person and have also your postpartum patients, which can get very overwhelming sometimes, especially when your backup that you get from the nursing floor has really no experience in OB. Like I've had a night shift where there's been like the 2 of us, and we've done 5 deliveries like before 2 a.m, and we also have all of our other postpartum patients. So time management is really your friend. Ideally, it would be nice to do 1-to-1. Oxytocins for sure are definitely 1-to-1. And then if you have postpartum patients, we usually are able to hand that off to your second nurse, and which is nice. But yeah, ideally that would be great, but sometimes you have to be flexible.
Same with us. It is 1-to-1 if possible. There's only 2 RNs on our floor as well. So we have to split whatever's on the unit. If there's a laboring patient, the one nurse will get that patient, and then the other nurse will take the whole floor, which could be Like we've had shifts. I've had a shift where I had 3 in labor and 6 moms and babies on the floor, and a sick baby that I had started an IV on, and just kind of had to manage that all in 2 people. So it can be unsafe sometimes, and that's why it's very important to put workloads in, because then nurses will never have any change. But in an ideal world, 1-to-1.
Perfect. Thank you, everyone. The next question is for Steffi. She's asking if there's any resources you guys recommend for a current nurse in LTC looking to go into L&D.
UBC has a great course in fetal monitoring that I don't know if everyone's required, but we take it every 2 years. You have to pay for the final exam, but the actual course is free. So you can go through all the modules without taking the final exam if you don't want to pay. But I don't think the final exam is that expensive. So I would say for sure a course in fetal monitoring, and then your NRP are kind of the 2 most important. And it was Steffi who asked that. I think like the willingness to have those courses. So I think, again, like I said, a lot of people who don't have experience in specialties are really intimidated to apply, because all job posting for specialties end up saying you need experience. But I know for sure at my hospital, like the willingness to learn and kind of educate yourself count as experience for sure too. So if you have those courses, I would definitely go ahead and apply places, and they'll recognize that you have those courses and you're trying for sure. So fetal monitoring and NRP, I think, are kind of the 2 big ones. RNAO has breastfeeding courses, which are helpful too, which are free, I believe, as well. But definitely those 2. And thank you for sending those, Emily. You're so on the ball.
Another thing sometimes managers like to see is that you're enrolled in a perinatal course. Usually you're to finish, especially if but like that. So a lot of like germs that George Brown does. There's a couple lines. So if you're wanting to do it soon, definitely take advantage of that, because it's nice that you can do those courses online at the time. You don't have to actually show up in class for those.
Awesome. Other things I would recommend is being part of, these extracurriculars and like RNAO groups, for example, being part of maternal child nurses. So you can connect and network with other nurses, possibly, get a little bit of a shoe-in with upcoming hiring dates or postings and things like that, or being part of CAPWIN, which is the Canadian Association of Perinatal Women's Health, I believe. So other things like that, just showing that you're involved and, you're putting that effort in to be part of this community and to network. Even joining webinars and educational sessions like this definitely all counts towards, showing your effort and trying to obtain a job in L&D or obstetrics in general. Yeah, please feel free to continue asking questions. I have a few questions myself that I will ask in the meantime. For all of you, we didn't really talk too much about it, but I wanted to ask about OR training and how that works at your places, or how often C-sections are done, if at all.
So I'm Michael Guerin. We have OR training just as part of our labor and delivery training. So we have 2 operating rooms on our unit that we use strictly for C-sections. The main ORs we go to if we have to, but we have our own operating rooms. So we are trained to scrub and circulate in our own operating rooms. And again, that's just part of our orientation. So when you're hired and oriented to the unit, you learn how to circulate first. And then once you're comfortable circulating, then we're trained to scrub on our floor. And it's, again, strictly for C-sections.
to kind of piggyback orally, the level 2 that I work at, that's exactly how our work. And then the level 1 that I'm at, our team, so they have a certain amount of time that they have to be. So we don't do PACU at that point, scrub or circulate. Our main focus is baby nurse. So we're baby nurse because as well you have the rest of the floor to watch. So it's nice working the 2 centers because you get a taste of both, but it's nice having the operating room nurses there because you can really focus on your mom and your baby and doing skin to skin with your mom and baby if time. Also, you're there for resuscitation. At our hospital, there's usually only the 2 nurses that have NRP. Obviously your doctor that's coming in does, so you really don't want the other nurse scrubbing or circulating because you need those 2 nurses NRP certified and ready to intervene if need be.
Yeah, my hospital's the same thing as Haley. We have 2 operating rooms that are like used for the entire hospital. Our OR team is there from like Monday to Friday, like 8 to 4, and otherwise they get called in and they have, if we call in a C-section stat, they have to be there in a certain amount of time. If it's called in urgent, they have to be there in a certain amount of time. That's obviously had its downfalls when there's currently a surgery going on and you really need to do a C-section, and there's just not an opportunity to do that, and you just have to kind of wait very impatiently. I have same thing also. I only am baby nurse, so I come in when I go in. I'm at the nursery at the warmer waiting for the baby, and in theory, most of our doctors that will be our doctor for the baby are NRP certified. Sometimes it's doctors who haven't done NRP for a very long time, so a lot of it's on you sometimes. But I can't even imagine what it's like to have your own OR just for OB. That'd be like really nice.
Coral, who does your C-sections? If you said all your doctors are family practice only, right?
Mm-hmm. Yeah. So the doctors do. They have there's not all of them are C-section training certified or whatever they do. I would say about half of our doctors that pick up on OBR. So there's always one doctor that does C-sections that's on per shift. And if we sometimes there's 2, like depending on how the schedule works out. And sometimes if there's 2 doctors that are on coverage for OB that aren't, then we have a 3rd that's just on call just for C-sections.
Thank you.
And ours is the same
And
thing.
is it like a general surgeon you have?
I don't know who asked that question.
Oh, no, go ahead. I was just saying that in our level 1, it's general surgeons that come in. Our family docs who have OB privileges, they just focus on baby at that point or assist, and then it's a general surgeon that does the section, so they have the training for that.
In ours, we actually have OBs. We don't really have family practice. We had one, but they don't really, and they would never be doing the C-sections. It would be the OBs, but similar situation in terms of only 2 ORs for the entire hospital. We don't scrub or circulate at all at Georgetown because there's only 2 of us on the floor. So the OR team would do that, and we would go in as baby nurse, and then PACU recovers the patient and we get them afterwards. Now they are trying to change that a little bit to get us to scrub and open, because of course there's situations like we said where there's a surgery ongoing and you need an urgent section and it's not possible because anesthesia and your whole team is in a case, which can lead to negative outcomes, unfortunately. So they're trying to work on that now. But at Mount Sinai, we actually do scrub and circulate, and we have 5 operating rooms on labor and delivery, which are our own ORs. And we would only use the main ORs there if we're doing a big per creta or something, but everything else is done on our ORs.
Thank you, everyone. I have some other questions. First, for Coral, I wanted to understand how your center decides if the baby gets transferred to London or Winnipeg, and is it just NICU bed dependent, like availability, or how many inter-province transfers do you guys usually do?
I'm not sure how many we would do in a year. It seems to kind of come in waves sometimes, where we'll send 3 babies out in a week, and then sometimes we won't send one out for a while. Usually we do get the NICU team from Winnipeg that will transfer the baby to Winnipeg, sometimes to Thunder Bay, depending on why we're transferring the baby. The only time we've had to have like London come up is because the wait for the NICU team from Winnipeg is just too long. So usually the London team will come up, pick up the baby, and then from what I understand, then they will transfer the baby actually to Winnipeg, not usually to London, unless there was like a really big space problem in Winnipeg. We transfer like babies for like a variety of reasons. If ideally, if they're requiring CPAP for more than a couple of hours, we would like to send them out because 120 a baby doesn't really work in our department very well. We have had babies sent out that are like extremely hypoglycemic, or if they're, we deal a lot with babies that have withdrawal. So if that gets to a point where we can't handle it as well, then we would transfer a baby out. We also have parts of our population that deal with a lot of alcohol abuse. So we've had babies that are born intoxicated that need a higher level of care that we also can't provide. So usually the NICU team, I would say, gets there like pretty quickly. Like I think the longest I've had to wait was like maybe 10 hours or so. And like the quickest they've been there is like 2 hours. It just kind of depends on like what they have going on, because they service like a big chunk of Canada. And I believe that there's only like one team that's like on at a time, I think. So you kind of have to just do your best until they get there. You want to hug them when they get there. They're so excited. But
That's awesome. Thanks so much, Coral. We have a question from Shanna. This question is regarding nursing students. Would you recommend doing your final consolidation in L&D if that is your future interest? Or do you recommend doing something else to gain a more rounded hands-on nursing experience before applying for L&D positions?
I think there's pros and cons to both. I think kind of getting your foot in the door is a good way to go about getting a position. So I think definitely if you know you're interested in L&D and you want to work there, I would recommend trying to get a consolidation there and making those connections. L&D is very specialized. Like you aren't going to get kind of that rounded, well-rounded med-surg experience. But if you're not interested in working in those fields, I definitely would say try to go for your consolidation there and make those connections and gain that experience. And if you kind of down the road want to work on a different floor, you can always get that experience later. But if you know it's something you want to go into, I would highly recommend doing your consolidation there if you can.
Sorry, go ahead, Pam. I totally agree with Orly. If you want to go for it, you do want to. For the one that I work at, actually during COVID, we were shut down for 6 weeks and we became med-surg. So that was scary for some of us who've never done med-surg. But we had a whole new scope, and sometimes we won't have any patients at all for a shift. So we go out to the med-surg floor and help them when we can. So that's learning as well. If anything urgent comes into emerge, we help them with what we can. So if you do go to a smaller community hospital, there is opportunity to learn it's maybe not as in depth as you'd like to, but to get some exposure. But as well, it's all about what you want. You could just sit on your unit for 12 hours and do your own thing if you have an empty unit, or you could just choose to go out there and float and just say, I want to learn, can I help you? Tag along with another nurse, and they're always happy to have you, even if it's just for vitals and meds and for you to kind of shadow them, but they're happy to have you. So if you're looking for the best of both worlds, I would totally recommend going to a smaller community hospital, because you can kind of have your cake and eat it too in a way, which is nice.
Shanna, to add on, I feel like if it's possible that your school can accommodate you securing an L&D consolidation placement, that would definitely be the best. If you already know, as Orly said, that's what your future interest is in your nursing career, or at least to start, because a lot of the times that kind of final consolidation is typically a long longer consolidation placement than all of your placements. So it's kind of like you get a half and half training. If you want to become a new hire, they'll really highly look at that and say that, okay, you've already worked with our staff, you already know the unit procedures, and getting into that team culture is definitely a big thing that I think obstetrics nursing looks at, because you really need that team flow and teamwork in general to have successful outcomes for your patients and for your team as well. So if you already know that's like your goal, definitely try to go for it. But obviously, if your school can't accommodate something, having an L&D or obstetrical consolidation placement, then any unit you go to, even like me in long-term care, there's so many transferable skills in any area of nursing that you just need to kind of sell yourself on, like, you know, building your leadership skills or time management skills, for example. That all adds into your L&D possibility of experience, and in your interview, you just need to speak to your strengths. Okay. Please feel free to continue to ask your questions. I have a few more for our panelists myself. For Orly, I just wanted to see if you want to talk about your teaching a little bit.
Yeah, so I work, I'm not teaching this semester, but I work for Seneca teaching first-year nursing students. So I've been doing postpartum nursing with a group of first-year nursing students, which I love. It's so nice. It's so nice to kind of see nursing students so fresh into their nursing career and just kind of shaping and exploring options and seeing what they like. And Emily, just to kind of build off what you said, like there's always skills that are transferable. So postpartum, again, is so specific, but like I teach people, like if you're not even interested in postpartum, like you're still making those connections, you're still doing head-to-toe assessments, you're still working on your communication skills. So there are skills that can be taught that you can use in different specialties, even if that's not something you're interested in going into. And I think it's good for me. Like I love teaching because you need to know 100% what you're doing in order to teach. So I think that's challenged me to kind of be better and be like perfect at my postpartum assessments and perfect at my like mom and baby assessments for sure. Because when you're teaching someone, you need to be able to teach them how to do it perfectly. So I think something I've loved about nursing is that there's so many options available to you. And one thing I told myself when I was in nursing school and working with different nurses in different settings was like, I'm never going to be a grouchy, miserable nurse who seems to not enjoy what I'm doing. Because the second you don't enjoy what you're doing, there's so many different options available to you. So teaching is something I found and I love it and I really enjoy doing it. And it's nice. It's a nice change of pace sometimes. It's very different than working on the floor and working L&D. And keeps me kind of up to date on best practice, which I really enjoy. So it's not something that you can go into immediately as a new grad. I don't know if everyone here is a new grad or just kind of looking to change into a specialty, but definitely something that I would recommend to look into for sure, and gives you a new insight on things and challenges you for sure to continue learning and educating and bettering yourself as a nurse. And I think ultimately it makes me better for my labor and delivery patients as well.
Awesome. Thank you so much, Orly. We have another question from Riddy. She asks, what are some common interview questions specific to L&D?
It's been a while since I've been through the interview process, but I think a lot of it is about like prioritization and time management. And if you have like two different scenarios, which I think are going to be kind of not specific to L&D, I think those are going to be just common interview questions for sure, but how you're going to prioritize your patients. And I remember being asked about a lot about like interprofessional communication, like when are you going to call the doctor? Why are you going to call the doctor? When are you going to call peds? Why are you going to call peds? So reasons to kind of reach out and work as part of your team versus reasons when you're going to manage and work autonomously by yourself. So just understanding those differences.
I have two questions for my interview that were burned into my mind, and I don't know why. Like Orly said, some of them are pretty standard, like across the board. I just remember the question from the CNO: what two practice standards can you apply? to the department. So I feel like that would be good for any unit. Last question I was asked was, you walk in the room, a mom is postpartum, she takes the baby off breast and the baby's blue and not breathing. So really what they wanted you to walk through there was just your steps of neonatal resuscitation. And it kind of catches you off guard because labor and delivery, you think when a baby comes out and they're not breathing. So it just kind of catches you to reshift your thinking a little bit to a newly born baby, but not super fresh. So in the postpartum setting. So they just wanted the NRP steps there.
Okay, thank you. Hopefully that answers your question, Rudy. If you have any more specific questions, please feel free to type that in the chat. Another question I wanted to ask each of you, just because you're all from such different centers a little bit, how often do you see midwifery or nurse practitioners in your practice, or just midwife patients in general?
The level 1 that I work in most of the time, we don't have midwife. There's no midwife privileges there. There used to be back in the day, but the level 2, there's lots of midwives. There's different teams, so we see them pretty often. And really, we're only involved if there needs to be a transfer of care and it goes from OB, from midwife to OB, or with epidurals. Actually, when anesthesia is starting the epidural, the RN has to assist. Then the midwife can the epidural. Their patients are getting an epidural started. But obviously, if they need help too, like some girls will just need a second set of hands. If their second team member isn't there, midwives work in pairs. So if they have someone precipitous coming in and they need someone else just to be baby nurse while they're delivering, we do that for them too.
We have a large team of midwives we work with. I think there's like 15 of them or so in their practice. And I would say like daily, there's a midwife patient on the floor. And again, similarly, so midwife patients are managed by midwives unless something turns atypical or abnormal, and then we have to step in and take over care. And I guess kind of on the flip side, sometimes they start with patients who have complications or something in their pregnancy, so they get transferred to OB, but then the midwives are there for supportive care for them. So we work closely with our midwives. I feel like we get along well and we have a nice relationship, but for the most part, kind of our patients are separated unless, of course, we need to take over care.
We do have a group of maybe 10 midwives total, but they don't come as often. Majority of our population of midwives, because they have privileges at Georgetown and at Brampton, and a lot of them end up delivering at Brampton Civic because I think a lot of patients are just worried about the not having a NICU and having to transfer the baby out if there's any complications. But we do get at least 1 to 2 midwife deliveries a month.
We don't have any midwives here. I've never had an experience with a midwife delivery at all, which is something I'd be interested in seeing. I guess would be kind of cool to work at a different center where and seeing how midwives do things. But I think the closest midwives that we have are in Thunder Bay, and I think they're only have privileges at the Thunder Bay Hospital.
Awesome. Very interesting to hear, because initially I would have thought that, in a more rural centers or places that there would be more midwifery presence just for that community care. But it's very interesting to see there's kind of a more concentrated population in the GTA. My next question to each of you is, what are some of the biggest challenges in your job as a labor and delivery nurse that you would like to share?
I would say losses. How is that hard? That's hard for everyone. And in time, I think you get a bit better at communicating with the patient, like anything, experience, and you really lean on your senior nurses to kind of guide you through those situations. Personally, for me, becoming a mom in the last year and then being pregnant again, things are a bit more emotional and you have to put things aside. When you have a sick baby, it just hits closer to home because sometimes you don't see your child, but it's just more personal when you have your own children, I find. And that transition has been really big for me. And then this year going back to work, I was empathizing with the moms who have felt emotional loss through COVID. I feel like I was able to empathize with them just from finding out you're pregnant, your ultrasounds, no partner being allowed in any of your appointments, and then being worried if your partner could even be in your delivery. And even now, no partners are allowed in appointments or ultrasounds. So those hit a lot of topics, but just those things, whether it's the loss of a child, the loss of being able to celebrate a pregnancy in the same way, I think, yeah.
I agree. I think bereavement and loss in general is really challenging, especially outside of work. So people think you work in labor and delivery, and for the most part, it is like a very happy place and very good outcomes, and it's an exciting place to work, but there are challenging days for sure. And I think like to friends and family, kind of understanding that when you come home at the end of the day after having a patient who had a loss, like it's challenging for people to kind of understand that when they think it's just like a always happy place to work. So like I mentioned at the beginning, I've definitely shown an interest kind of for myself in bereavement and losses and how to help support our patients, because it is like a complete 180, a complete different type of patient than we're used to dealing with. And thankfully we don't deal with it often, which is very nice. But at the same time, when you're not seeing it so often, it's hard to kind of flip that switch and go from what you're used to saying and the way you're used to communicating with patients and think like, how do I change or phrase the way that I'm speaking or saying to these patients while still providing them good care and still showing empathy and still kind of making this their birth story and making it a good experience for them. So Emily, you just added it there, which is perfect. But Pale Network through Sunnybrook has so many great resources, and they've definitely helped me for sure in providing better care to bereavement patients. But that's definitely the most challenging part of the job, and something that people I think need to be aware of, but it's not what people think of kind of going into labor and delivery. So it's something to know that at least for us, we don't deal with it often, but it is something you do have to deal with. So something to consider and think about for sure.
I would say some of the challenges, of course, bereavement is one of the biggest ones. But also managing, like for me, I would say at Georgetown would be just the whole management of a mega code, because knowing that we have a respiratory therapist in house now, luckily, but it's just you and that respiratory therapist to run the entire code. Peds aren't in house. If there is a baby that is coding, they usually arrive 30 minutes into the code where you've already done all your resuscitation. And then sometimes the babies that you resuscitate that still need ongoing support, we then get, because our babies are mainly transferred out to McMaster or sick kids if McMaster is full. So then like the pediatric fellow from the sites will usually call and give additional orders of how to manage the newborn. And sometimes that could be really, really stressful when you're going through, the whole thing of like volume expander pushes through a UVC and all those things where NICU isn't your specialty because you're a labor and delivery nurse. So I would say that is one of the biggest challenges. And also just managing, I know no one mentioned it because it's not as common, but maternal emergencies. So someone that's coding because they've gone into DIC and they're bleeding out and you can't really control the hemorrhage. I've had a patient at Georgetown that was a huge code omega, and after about 25 units of blood, we had to airlift her to another facility for embolization. So luckily she did make it, or even managing amniotic fluid embolisms, I've been in that situation. So I think those are like huge challenges that aren't always mentioned in labor and delivery, but definitely can happen.
Basically the same thing everyone touched on, dealing with with loss of through stillbirth, or if a baby doesn't like make it through a code, or we had a maternal death about 2 years ago that was like, and because you work in like a small center, you like we saw like this mom like throughout a lot of her like prenatal care and everything like that, so you develop a lot of bonds with people, and that can make it very difficult when emergencies happen. I would say also, also just working in a smaller center, you see a lot of people that you know personally. So your coworkers and your friends and sometimes family members. And that can be kind of like, for me specifically, can be just kind of nerve-wracking because you don't want anything to go wrong. And when something doesn't go the way it's supposed to, or if you just don't have an outcome that you expected, or like a mom ends up going for like emergency C-section when that wasn't part of her birth plan, trying not to take too much personal, like try not to take that too personally and putting all that blame on yourself for that, just because this is somebody that you know. Like I've had some of like my best friends have their babies like come in like while I'm on shift, and I'm just really hoping I'm not there because I don't want that responsibility. But that's bound to happen when you work in smaller centers, especially like where I work. Like we're a very isolated town. Like our next town is like over an hour away, and so it's like you're it. So it can be kind of intimidating, and you hope for the best outcomes and everything. You do the best you can, but that can sometimes be a bit of a challenge in working in rural nursing sometimes.
Awesome. Thank you everyone for sharing that. I'm sure, again, it's that kind of that light of L&D that people are really drawn to, and then they get there and then they're kind of a little bit overwhelmed with all of the roller coaster of emotions that can happen with medical emergencies or psychosocial situations. So I think it's really important to highlight some of those challenges that, nurses can go through. Another question I had was, we talked about snippets here and there, but just a brief overview of what a kind of typical day in the life of an L&D nurse is.
Can I go off topic for 1 second? To loop back around to resources, someone asked a question about resources you recommend. I don't know if any of the other nurses here follow, but there's an Instagram account called Bundle Birth Nurses. It's run by 2 nurses in the States. I honestly think it's the best resource. All the nurses on my floor are obsessed with it. And it's a really good, like kind of easy resource to follow. So they post stuff daily. On Tuesdays, they have like Tracing Tuesdays while they review tracings. They offer courses too, which are quite pricey, and I haven't taken them, so I can't vouch for them, but it's just like an easy account to follow that is a great resource. So definitely something to follow and get into if you're looking for resources.
Yeah, highly agree. They have, especially the best thing about that account, I think, is that they're graphic images, but it just shows the real of like, knots, true knots in, the umbilical cords, or bilobe placentas, or things like that, that you can't really, find or in textbooks and things like that. They give you that kind of real imaging and descriptions and, real life scenarios that happen all the time, but, aren't celebrated or advertised as well known. We do have a question from Shanna, just to continue on from our conversation. How do you prepare for tragedies, changes in birthing plans, and medical cases that are not your typical?
I think you can't really prepare for any of that, but I think just knowing what your possibilities are and what your options are, and kind of being prepared for anything. So knowing that anything can happen. And I think communication is key. So I think I'm very open in my communication with my patients. So I'll never lie to patients. I'll never say everything's great if everything's not okay. And I always try to keep them kind of up to date on what's happening. So if there's any issues with the tracing or any issues with them or how labor is progressing or things are going, I will talk to them and say, like, this is our concern and this is what might happen and this is our plan moving forward. And then just being open and saying, like, this is our plan as of right now, but in a minute this plan can change, and ultimately reassuring them that we are here to support them and doing what's best for them and what's best for baby. So we'll never make choices that will harm their health or baby's health. And then I think I said it, but communication plays a huge part there too. So just communicating with the nurses you work with, the doctors you work with, and saying, like, this is what I have. We're not sure where it's going to go, but possibly this way, just so everyone's on the same page. So if like something does change quickly, everyone's kind of on the same page and knows what's happening.
I think also what's really important
To kind of go off you, or
Pamela, I think
go
you-
ahead, Pam.
Oh, sorry. I was just going to say, I think what's also really important post-traumatic deliveries is debriefing with your team. I think that that's always really helped me, because to a certain degree, you'll always carry a bit of that emotional side home, or, you know, if a baby doesn't make it through a code, it does kind of really impact you. And I think part of the problem is a lot of nurses are just accustomed to traumatic things being seen as normal when they're not. So it's really important to have a bit of time to sit down and debrief with the team after. I found that that's always really helped me. What did we do right? What could we have done better? And that always is also a huge learning opportunity moving forward.
That's exactly what I was going to say, Pam. Debriefing with your team is so important. So nothing can really prepare you, but you can choose at the end how you're going to cope and move forward. And
All right. Thank you, everyone. So back to just a quick typical day in the life of an L&D RN, if anyone wants to describe that a little bit. I think each center is so different, so I feel like, you know.
Yeah. Yeah, I was going to say every day is different. There's never necessarily something as a typical day, but at least at our hospital, we come in the morning, we do handoff with the nurses from the previous shifts, going through each patient that's currently there or patients that we're expected to see that day. If there's, and then we divide up between if there's somebody in labor and if there's any postpartum patients, we divide up that between ourselves based on if someone had somebody the previous day or is more familiar with somebody, or if somebody would just rather do a labor than do postpartum stuff that day. So after we do that, you usually go check on your patients. And then the day just really kind of just goes anywhere from there. At our hospital, we run, there's a prenatal clinic that's run in the hospital Monday to Friday that the doctors that are on call for OB run during the day. And then we just call them for like when we need them on the unit. So on weekends, not so much now because of COVID, but previously we would basically be running prenatal clinic on top of a labor and delivery floor on weekends. So you have postpartum moms coming in, you have moms that need like NSTs or inductions or whatever during the day. And it's like hard to describe a typical day. Anything can kind of happen in a typical day. And then we have scheduled C-sections usually on Friday mornings or Tuesdays at end of slate. So that kind of throws a little bit of a different thing in your day too. But yeah, it's hard to say what a typical day is like.
I think like we have three kind of main categories of patients. So we have elective sections every day. So 8 o'clock and 4 o'clock, we have elective C-sections booked. Patients who are spontaneously laboring, and then inductions. So depending on kind of what type of patient you're assigned to, your day is going to be different. Induction patients, it's kind of a lot calmer and more scheduled. So they come in make a plan for induction. Usually you start an IV and it's kind of a smooth ride into things. Same with elective sections, but laboring patients, you don't know where you're going to get that patient. Like you can walk into a patient pushing, you can walk into a patient freshly postpartum, you can walk into a patient who is screaming in pain and wants an epidural or doesn't want an epidural. So kind of what stage you get that patient in labor, your day is going to be totally different. So yeah, no typical day, but that's kind of what keeps it exciting and fun for sure, and keeps you on your toes.
Awesome. I have a question for Pam. Being able to see, you know, the differences between a community hospital and a high-risk center, what is kind of your outtake on either or do you recommend, you know, people starting out in community and getting their basics, or just kind of rushing into a high-risk job, or what is your take on that?
So I would say it's better for people to start in a bigger center where there's more support. It doesn't necessarily have to be a high risk level 3, but maybe like a level 2 hospital, just because then you're not completely on your own. There's always someone that you can ask for help, and it's not just 2 nurses. You have a bigger team. You have an NICU and peds that would respond to codes. So like for instance at Sinai, it's almost like nice for me because I know I can hit a button on the wall and I'll have 20 people run into the room, and I'm not on my own. So for instance, when I had a cord prolapse at Sinai, from the time I hit the code OB button to the time baby was out was 3 minutes. Yesterday, or the day before yesterday, I worked a night at Georgetown. I had a cord prolapse and it was 33 minutes, and I'm alone with no OB in house, and managing that is completely different. So I would suggest starting out as a new grad, it's best to start in a center that's a little bit bigger where you're not all on your own, because that could be very stressful and overwhelming. However, skill set wise, I would say majority of my skills do come from the level 1 because I am alone and I've had to learn how to make decisions. Or if someone comes in where I'm triaging them and they have epigastric pain and headaches, then I don't even call the doctor. I put in all the orders for PIH and call them afterwards, because we have kind of that relationship that you know what you're looking for, do work them up, and then call us with the results. Also VAG exams. I know that's a thing that's challenging for people to get good at in the beginning. And working at a big center like Sinai, nurses almost never do VAG exams because the residents are doing all the VAG exams. So I really didn't get good at my VAG exams until I was at a level 1, where I have to do the full assessment and call the doctor and tell them exactly what's going on, because we don't have the residents to be doing that. So definitely starting off, I would say better to be in a bigger center, but to build your skill set, it's better to be at a smaller center.
That's awesome. Thank you so much, Pam. I think that's really good, helpful information, especially for people trying to decide, you know, where to apply, what are going to be the biggest differences between working in a community versus a high-risk center, or even just, you know, a city center where there are lots of resources in the area. Like even for Orly at Michael Garron, even though they're technically a community hospital, they are so close in vicinity to sick kids and to us at Sinai. So if there needed to be any baby transfers or even maternal transfers to like Toronto General in the ICU, it is all in close proximity. Whereas I'm sure for Haley and Coral, it's a little bit more, you know, a reach to have those transfers in a timely manner and things like that. Okay, so I wanted to see if anyone had last minute questions. Please post now or unmute yourself. Otherwise, if Orly, Coral, Haley, or Pam, if you guys have any last words of sentiments to new grads, current nurses, thinking about obstetrics, feel free to share that now.
I will say we are hiring right now at Michael Garron, which is exciting. So I don't know if anyone is at that phase of applying and looking for jobs, but I'm happy to leave my email. Emily, is that okay if I leave my email in the chat? Like if anyone has questions, I'm happy to kind of chat more, or you can reach out to me. But definitely we're hiring. So as long as you, like I said, kind of show that enthusiasm and have those courses underway, then it's definitely, I love it. I'm biased, but it's a great place to work and I'm very happy there. So definitely reach out. I'll leave my email now. If anyone has further questions at all, I'm happy to help.
I'll follow that with, we're also hiring right now. We have, I think, 2 spots that are open right now in our department, and we've pretty much pulled all the nurses from the floor to our department that have been interested. So we're looking for some outside people. So, I mean, I feel like I made my job sound like extremely terrifying, but like it's actually a lot of fun. And we have such a great team that we work with. Like we are so close with our doctors and the rest of the staff, and I just really love the people that we work with. So, I mean, if you're interested and want to come have a Northern experience, I can also leave my email in the chat too.
Pam or Haley, any last words before we end off the webinar today?
Yeah, just go for it. If you have an interest in Mat Child, just go for it. Like we've kind of talked about, it can be daunting to start somewhere that is so specialized, but it gets better in time. Maybe the first 6 months to a year, you get nervous, but as time goes on, things can only get better. Pick up all the shifts you can, if you can, because that's how you're going to learn, is being there and being present. Obviously, take time for yourself, but pick up all the phone calls when they call in, because we're always calling.
I agree. Definitely just go for it. Confidence will come with time. That comes with experience for sure. But like, I can't imagine doing anything else. Just be eager to learn, and people will always be willing to help. So do what you always wanted to do.
Love that. Thank you, ladies, so much for participating today and sharing your words of wisdom and great amounts of experience. Thank you all to all the participants that stayed with us this long. And just a reminder that this webinar is recorded and will be posted on our website, www.mcnig.ca. Please give us a follow on our social media for other exciting upcoming webinars and educational events, as well as to network with our group. And that's on Instagram at mcnig.rnao and on Facebook at Mat Child Nurses IG. So thank you all and have a lovely, lovely afternoon. And I hope everyone enjoys the rest of the day and learns something new today. Take care.
Thank you.
Thank you.